Hey everyone, welcome to this edition of the CHP Spotlight interview series. Today, I am really excited because we are joined by Dr. Ronald Paik with Nerschel Orthopedics in Arlington. Dr. Paik, he is an orthopedic surgeon and sports medicine physician specializing in treating complex disorders of the shoulder, the elbow, and the knee. And Dr. Paik's goal is to pursue non-operative treatments whenever possible, but he's very experienced in advanced arthroscopic procedures, surgical repair, and reconstruction, as well as joint replacements. So Dr. Paik, thank you so much for joining us today.
Yeah, thanks for having me. I really appreciate you having me on this.
Absolutely. No, we're excited. And by the way, for anybody watching this who wants to find Dr. Paik, again, he's with Nerschel Orthopedics. You can find them at Nerschel, NIRSCHL.com. I'm also going to put the link underneath the video if you're watching this on YouTube, or if it's on social, I'll include it there as well. So before we get started, I want people to learn a little bit about you, Dr. Paik, and I see that you specialize in sports medicine, focusing, as I mentioned, on the shoulder, elbow, and knee. So I'd love to hear, what are the most common sports medicine type injuries that you see in these different areas?
Sure. Yeah. So, starting off with the shoulder, usually sports injuries related to, definitely overhand athletes is a very common situation where, baseball pitchers and throwers, as well as, volleyball players commonly can get shoulder issues. But we really see it in really anyone that's active as well. So weightlifters get it very commonly too. But within the shoulder injury spectrum, commonly the injuries that we see are labral injuries related to the cartilage structure that rims the socket there that helps stabilize the shoulder. It's a very common injury that people get from a common fall if they happen to dislocate their shoulder. Typically means they have a labral tear as a result, or overhand athletes get tears at the top part of the labrum, at the biceps attachment. So those are very common too. Rotator cuff injuries are also very common. Everyone can really get those. Unfortunately, it is something that oftentimes is associated with age. So everyday people, not necessarily athletes, get rotator cuff injuries very commonly. So those are very common within the shoulder, and then other just common traumatic injuries as well that we see with fractures around the shoulder too, are also very common. And then kind of lastly, biceps issues, which are not really understood as well commonly out there. Everyone thinks the biceps is more connected to the elbow, which it is. But the biceps in the shoulder is one of the most common pain generators in the shoulder that's commonly seen, and actually oftentimes very well treated by physical therapy, which is fantastic. So for shoulders, those are the common ones that we tend to see. Elbow definitely runs the gambit too. With the elbow, by far and large, I tend to see a lot of tennis and golfers' elbow. Although even though they're coined tennis and golfers' elbow, they don't commonly always happen for tennis or golf. The funny thing is the most common cause is actually typing a lot on the computer can cause irritation of those tendons. Even though the pains at the elbow, the tendons involved with those are really the muscles and tendons you use to move your fingers and your wrist, cause those issues. And then also for us with Dr. Nerschel, who is the founder of our practice, he's world renowned for treatment of tennis and golfers' elbow, and he was kind of one of the people that really discovered a lot of what we know about it. So we see it to a very large volume. With the elbow, also common issues are more related to baseball players, such as Tommy John issues. We definitely see also nerve issues around the elbow, particularly cubital tunnel syndrome is a very common issue too. But very similarly to the shoulder, a lot of these actually are very amenable to treatment with physical therapy. So it's great being included on this to really highlight the benefits of physical therapy. And then for the knee, common sports injuries we see there, meniscus is definitely number one. And then for other issues such as traumatic injuries, ligament tears are another issue. Arthritis, is an issue too. But definitely a lot of tendonitis. We see it throughout. So in all the body parts, tendonitis is another common concern, often related to overuse or just using it more than the tendon's conditioned for. So those are all common things we see.
Gotcha. I appreciate it. And that's, really comprehensive too. I really appreciate you, sharing those different things that your patients come in with. And now for these various different ailments, whether it be at the knee, the shoulder, the elbow, would you mind shining some light on what are some common risk factors that you see that may determine or may send somebody your way for a consult in any of these with any of these pathologies?
Yeah, so there's a lot of different things that can be risk factors. Number one is it's conditioning to some extent. So, a lot of with muscle tendon related issues, a lot of the tendonitis, fall under the umbrella of overuse syndromes. So typically that means that you do something that the muscle and the tendon are not conditioned for, and then you irritate it. The problem with a lot of tendonitis related concerns are that the tendons in the body, their blood supply is very poor. So oftentimes if they get triggered or irritated, they just don't have a mechanism to fully recover and heal themselves, which is why physical therapy in particular is very helpful for that, getting to the heart of the mechanism. So it really helps recondition the tendon by the action of conditioning the tendon through rehab exercise and different modalities. It helps improve the blood flow to really get to the heart of the problem. So that's a risk factor in and of itself, is just if your lack of conditioning or coordination. With a lot of baseball players in particular, a common risk factor for throwing level injuries is just particularly fatigue, or if you start changing your mechanics when you throw due to fatigue or something hurts. So even if your shoulder hurts when you throw, there's a higher risk you can blow out your ulnar collateral ligament, which is your Tommy John ligament, just because your mechanics change and you're putting more stress on the ulnar collateral ligament. So even with that, there have been many biomechanical studies that show us even, the torque on one throw in a pitch oftentimes meets or exceeds the tensile strength of that ulnar collateral ligament. So even just one small throw and you throw it off, you can pop your ligament, even if you don't have a pre-existing problem there. So kind of things related to conditioning are very important, and also coordination with ACL injuries. We know there's a strong correlation with mechanics as well. So if your landing and jump mechanics aren't really normal, you're at high risk of an ACL injury too.
Absolutely. I appreciate you mentioning that. And I love that you mentioned sort of like the loading tolerance of a lot of these tendons and soft tissues in the various joints. It's such a great, just overarching concept in general for being resilient to some of these issues. I know I love the analogy of, I have my coffee cup here, and I kind of use the analogy of, okay, when we do some of these sort of strength training or loading drills, oftentimes what we're trying to do is just improve the loading tolerance and the capacity of what those tissues are able to have. And then ideally, like with the cup analogy, like when the pain or injury occurs is when the cup overflows. And so ideally with some of that loading, you can kind of make the cup bigger. So it just takes more and more sort of liquid for the cup to overflow. So because I think sometimes some people, some of our patients think that by doing that also, like that we're never going to have a limit, and we'll always have a limit, but ideally we can sort of make the cup as big as possible. And I think that's really awesome that, you understand that. And because, it's always hard because then it gets into like the rehab side, and obviously then we can sort of bridge that gap from the surgery to the rehab side, and vice versa. So that kind of feeds into my next question, Dr. Paik, which was, what are some ways that someone can differentiate, or I guess how would you explain to a patient how they would be able to differentiate whether or not surgery might be needed for the knee, the shoulder, the elbow, because you're such an expert in being able to understand all those different worlds and how they sort of collaborate and interact?
Sure, that's a great question. Yeah, I mean, in terms of whether surgery is needed, it may be hard to have just a layperson really identify it on their own. Really surgery is only required for predominantly structural injuries. So if you have like a structural tear, that is never going to fully heal itself typically, unless we surgically reattach it. So I commonly describe it as, you have a mechanical problem, you need a mechanical fix. We have to reattach it, it's torn. Just like you would see in everyday life, if, say, and I commonly use the description of tendons are like, towing something. If you tear the connection between the toe hitch or something else, or you're using a rip to tow something and you tear that connection, it's not going to somehow fix itself. You have to fix it and reattach it. So, but for a lot of other things, with tendonitis related issues, without question, those respond, I'd say, really favorably and really best by rehab exercise. I sort of describe it more as like a biologic problem, and the fix is address the biology of the tendon and address the biomechanical structure of the tendon through exercise, where it's not a structural injury or tear. It's just, an issue with the the actual fibers of the tendon just not being conditioned. So you really, the goal is, again, you just condition it. But there are other tears, things like in the shoulder with the labrum, even though, I mentioned the concern about structural injury or tear, but most labral tears do not need surgery. They usually are amenable to treatment with rehab. Again, the key being just to try and really condition the shoulder so that way we can reduce the symptoms. And labral tears, unless you're having instability and recurrently dislocating your shoulder, do pretty well, at least with full reduction of symptoms potentially with rehab. So in terms of trying to differentiate whether surgery is needed or not, I most likely in the end, if number one, in terms of whether to get evaluated or not, if usually my rule of thumb is if the pain lasts for really over a week or two and is not getting better on its own, or getting better if you're trying to rehab it on your own, then probably get it checked out. And then that way we can kind of determine, what it is, and if there's any concern that we need to get advanced imaging, because in the end, oftentimes I can't say with, 100% certainty that something's torn unless I get an advanced image like an MRI or X-ray. Although X-rays don't really show a lot of tendon tears, but sometimes they give us secondary findings that make us, concerned about it. But if I'm suspicious of it, the only way I know for sure too is to get an MRI, oftentimes for tendon or ligament related injuries, to confirm. And then based off of that, we have that discussion. But if the suspicion is pretty low off of an exam in the office, where it really looks like more of something that could be treated best by non-operative treatment and rehab, then we'll go in that direction.
Got it. That's super, super helpful to know. And then, I know in the past we have chatted a lot about some of a lot of the mutual groups of people that we tend to work with, being like the sort of active athletic adults and the youth athlete. In those two audiences, and I know there might be a different answer for each because they generally are, because they're a different age demographic. Are there any ways, we mentioned strength training, are there any other ways or any things that you have recommended to any of these populations so that they can maybe reduce their risk of injury, or so that they ideally don't have to become, a frequent flyer with either of us?
Sure. Yeah. I mean, the key thing is really, it is the conditioning aspect and coordination. Youth athletes, one concern is just, especially like for teenagers that are in a growth spurt, the coordination kind of gets thrown off a bit, just because their skeletal, body is really outpacing the muscle development and everything else. So coordination ends up being a little bit more of a concern. Although thankfully their tissue and their muscles tend to be a little bit more elastic. So a little reduction in terms of risk of tear than it would be in an adult population. But that's really the key is it's a conditioning issue, particularly for injuries. And for like knee ligament issues, again, it's coordination. ACL tears generally happen due to very well-known biomechanical risk factors. Although you can't fully eliminate them, most high-level pro athletes have done many drills to help reduce their risk of ACL tears, and they still get them. But it's just one of those one-off things that can happen. But it is pretty well established that you can do certain things to help reduce the risk. And then again, for older patients, a lot of tendon ruptures happen just again from overload of the tendon. Achilles ruptures are one of the most kind of hallmark tendon ruptures that happen from an overload and usually due to a deconditioned athlete. So we call it the weekend warrior injury, where it's usually the 40 and above year old, in terms of demographics, it's male. That's a quote unquote weekend warrior that tries to relive their glory days of when they were a high level athlete as a teenager or 20-year-old, and who doesn't normally exercise and goes out and plays a sport, plays basketball, and takes that one quick lunge and step, and they pop their Achilles. So, and that's usually a conditioning injury.
Absolutely. I appreciate you mentioning that. And I love the name of the weekend warrior injury because it definitely connotates some of the root cause in it, right? It's a lot of times as we get older, and I know I talk to our patients that are these active adults all the time, and that, age is certainly a risk factor. And part of the age, I think, is also the behavior that right, we have different lifestyles when we get older than we do when we were younger. So although, your tissues don't have the same sort of a loading capacity and resiliency that maybe they once did, that part of that also is that, maybe we're a little more sedentary during the week. And then all of a sudden, you're sedentary maybe 5 days, and then Saturday comes, you got your adult basketball league, and now you've had the car sort of in the garage all week, and now you're going to go floor the engine. So it's a big transition.
It is, definitely.
I love that. So super illuminating. And one thing that's interesting, I wanted to ask you more specifically is, you mentioned earlier Tommy John surgery and the medial elbow stuff. Now, it's interesting because in the area we see a lot of baseball players. I know we've talked about that. We see a lot of baseball players at our practice, and it's rare to find a great person who really specializes in seeing these, because it's kind of niche. And I know you see a ton. So I would love to hear from you more specifically some of when you see, let's say, a teenager that's coming in with that medial elbow pain. Let's say it could be the first incidence this is coming on. What are some pieces of advice you typically might give to the athlete and most likely their parents as well?
Yeah, so I mean, if they're coming in already with an injury, then it's number one, figuring out what it is. Medial elbow pain. It could be really kind of predominantly three different things. The common ones, number one is the Tommy John ligament, the ulnar collateral ligament. It could be the common flexor pronator tendon, which is actually commonly coined and tied to golfer's elbow or medial condylitis. The other issue is ulnar nerve issues. So due to the repetitive stretch of the nerve, it can cause some irritation. So all three issues are common medial elbow pain or inner elbow pain issues in high level, baseball players, or not even high level, but baseball players. And in younger players with open growth plates, it's what we call little league elbow, which is basically irritation of the growth plate of the medial epicondyle of that elbow, which I call is essentially the teenager or child equivalent of a Tommy John related issue. It's just increased stress on the area, but instead of the ligament tearing, thankfully, it's just the growth plate is irritated. So I mean, it's just depending on what it is, figure that out. But in terms of counseling athletes, as far as like risk factors and things to be on the lookout for, with especially with youth baseball and just baseball in general, we know that with baseball players and with overhand athletes, there's an intimate relationship between the shoulder and the elbow. So again, as I alluded to before, is that if there's an issue with the shoulder, you're at increased risk of an elbow problem, and kind of vice versa. A common issue that can result in overload of the ulnar collateral ligament is something that based in the shoulder called glenohumeral internal rotation deficit, which is a common issue that overhand athletes can get, whether you're young or old. And it's also tied to something called internal impingement that can cause even a rotator cuff tear in the shoulder. But it's very common for overhand athletes to get tightness of what's called the posterior capsule in their shoulder due to repetitive throwing. And a lot of high level throwers, and usually like high level college athletes, and a lot of high school coaches are fully aware of that issue. So they really harp on the posterior capsular stretches. Traditionally we call them the sleeper stretches, or a few other stretches that you can do to help keep that loose. But the problem is biomechanically, when that happens, it creates an increased torque on the medial elbow. So again, it gets to that increased risk of rupturing the Tommy John the Tommy John ligament or the ulnar collateral ligament with one throw. So that's something that in every overhand athlete, when they come in for a shoulder or an elbow issue, that's one thing I check. That basically the check for it is generally have the athlete in a supine position, and then we abduct the arm. So just bring it out to about 90 degrees and check external rotation to internal. That's correct. Yeah, and the arc of rotation should always be roughly about 170 to 180 degrees, and it should be very equivalent to the other side. So the total arc of motion should be the same. But what you'll see a lot of times in overhand athletes is they'll develop a compensatory increased external rotation, which allows them to potentially, wind up and throw harder. That develops with time. But the key thing is the internal rotation or the total arc should still match the full arc of motion. But then when you see this posterior capsular tightness or glenohumeral internal rotation deficit, yes, they'll still have the increased external rotation. So maybe they go beyond 90 degrees, they go back to like 100, 110. But then the internal rotation should match. They should internally rotate to 70 degrees or so. But then you'll see a lot of times they just go to neutral or go to 20 degrees. So then you can diagnose it that they have glenohumeral internal rotation deficit. So again, it increases the risk of Tommy John. So that's why it's really important to do the stretches. I recommend definitely after you throw, just to keep the capsule loose, and then ideally before, just to make sure it's nice and loose before you throw. And the key thing is always do an adequate warm up. Don't go out there and throw cold turkey, or else again, the muscles and everything else are not as coordinated, number one. But number two, it's once you warm up, you improve the elasticity of everything. So decrease the stiffness, which then can cause a tensile rupture or an overload. So.
Gotcha. I appreciate you sharing. That's super insightful, and I definitely love the perspective in terms of, somebody comes in, I got this medial elbow thing. Like, yes, of course, first it's the most important to figure out exactly what the structure is. What is the source of the discomfort, like that's actually sending those pain signals? Then if it is the ulnar collateral ligament, Tommy John ligament, then looking up the chain and seeing, okay, is there anything happening more proximally that's putting more stress on what's happening down? Because if we're not functioning as optimally as we get closer to the center of the body, then we may have to compensate further down to try to make up for it. And I know one thing we see a lot with a lot of the high level athletes that we will work with, like whether high level high school, whatever the case might be, is part of what makes people great athletes is they're great at compensating. They're great at getting the job done in whatever way they need to. So they'll figure it out. The problem is it might not be a great long-term solution. So those are some great indicators there. And I really appreciate you sharing that. And so with that being said, before we finish it up, Dr. Paik, and our patients that have seen you all have great experiences. They have tons of great things to say. So I'd love to hear if you have anything to share more about how you approach patient care at Inertial Orthopedics. I'm sure everybody here would love to hear about it. And then most importantly, how can they find you?
Sure. Yeah. So in terms of our thought process on helping patients, again, every patient's an individual and has different motivations, different goals. So the key thing is trying to really understand what the goals are, and also what the issue is, and really match those. So the treatment for one patient with the same injury may not be the right treatment for someone else. So it's really trying to figure out what really everyone's individual concerns and goals are. So it's really important for us to get that understanding and really talk to every individual patient. So that I think is really an important part of care, and also for patients to really feel like they've successfully healed the way they want to heal. So, but in terms of getting a hold of us, definitely the website is an easy way to access information about us. So it's the Inertial, NIRSCHL.com website. Our office phone number is 703-525-2200. It's an easy way to make appointments as well. And then also on the websites, there's some email addresses there. They do go to our direct assistants, but our assistants will flag them for us if there's questions. So we're always happy to answer questions really anytime.
I appreciate you sharing that, Dr. Paik. And it's I will say for our patients again who have seen Dr. Paik, seen his colleague at Inertial Orthopedics, it's definitely very personalized. They get that there's that nice personal touch. People leave with that clarity at the very least as to what they need to do next, which is just so huge. And so I definitely highly recommend it, especially for anybody in the Arlington area. I'll put the contact information below the video so you can reach out to Dr. Paik with to schedule an appointment, and he ask the front desk any questions, things like that. But with that being said, Dr. Paik, thank you so much for joining us. I appreciate you sharing everything.
Yeah, thanks again for having me. I really appreciate doing this. Enjoyed it.
It was fun.